Excellent. Well, thank you so much. For those that are here and for those that are watching on the World Wide Web, thank you for joining us today. My name is Ryan Longnecker. I'm an interventional cardiologist at Freeman Heart and Vascular Institute in Joplin, Missouri. I was asked to talk about ST elevation myocardial infarctions and kind of walk through some of those things today. So for disclosure, I really don't have any. I have done talks for Pfizer and Bristol Myers Squibb in the past, but that has not been for a few years now, and I don't have any conflicts directly related to this talk. No worries. Go right ahead.
Do you see anything over there now that's changed?
No.
Let me look on your
Sorry, I guess we're having some technical difficulties.
I still have a black screen and I posted on there.
That side over there would be about 30 seconds away or so. You had it, didn't you?
Yeah, I didn't have it at the beginning there. It's running.
Oh. We lost connection for a setting inside of the MacBook. Yeah, we've lost it. Yeah.
I just accepted again.
Okay.
I don't know if that may.
For some reason, it just
That's what it was. That's what it was. I got you back there.
Well, hopefully we don't have to reconnect multiple times,
Yeah,
but
it's not happened. This is the first time it's happened.
okay. Well, love that technology. So regardless, we're back, I guess, for now. I have nothing to disclose with regards to conflicts of this talk. So some of the objectives that we want to talk about today, actually, let me grab my laptop so I can actually look at it while we're going. This will hopefully help as well. But first thing being, what is a heart attack, specifically an ST elevation myocardial infarction? What are some of the presenting symptoms and the characteristic EKG findings that we might have? Some of the treatment options that are available in 2025, whether it be fibrinolytics or primary percutaneous coronary intervention. Why we talk about this 90-minute door to balloon time so much, to really focus on patient care. Some mechanical support options that are available to the patients, and then what we call post-STEMI care, or the ABCs of cardiology. So first things first, what is a STEMI? It's a specific type of heart attack that has characteristic EKG changes. It usually occurs in males greater than 50 years old and females greater than 60 years old, but it really can happen at any age. Particularly in our patient population, we're kind of seeing it younger and younger, and certainly when there are other things like drug use and some bad kind of actors like that involved, all bets are on at pretty much any age. It does usually, when somebody has a STEMI on their EKG, it usually signifies a complete occlusion of one of the coronary arteries. Interestingly enough, it may not be present on the presenting EKG, which is why we do subsequent EKGs when people have ongoing symptoms. Even with ideal care in 2025, it can still be fatal. So when we look at a STEMI and the EKG breakdown, we kind of want to look at various leads, particularly, we look at the anterior leads in V1 and V2. That's kind of the anterior septal, if you will. V3 and V4 are the anterior leads. V5 and V6 are low lateral, with high lateral leads being 1 and AVL. And then the inferior STEMI and the inferior leads as well. So we kind of looked at, and when somebody comes to the catheterization lab, we look at that EKG to help us localize which coronary artery we think is going to be involved. So that way we can get our equipment selected appropriately. So this is an EKG with examples of an anterior STEMI, particularly if you look at V2, V3, V4, and V5, you'll see those tombstoning ST elevation. That's pretty classic for that. This patient is actually already queued out, which would suggest that they have pretty impressive Q waves and have already infarcted a good portion of that muscle. So even though they have revascularization, they may not get the full benefit of that because some of that muscle has already died. This is a lateral STEMI, so if you look up here in leads 1 and AVL in particular, you'll see that ST elevation. This is kind of that hyperacute T wave phenomenon as a part of the ST elevation, but definitely some reciprocal changes down here in the inferior leads, consistent with the lateral STEMI. The inferior STEMI, this is pretty classic, leads 2, 3 AVF. Again, you have ST elevation, you have a little bit of reciprocal depression there in AVL, and then some ST depression or elevation over here in V1, suggesting that there might be more to it than just the right coronary. And then the inferior posterior MI, people talk about these a lot, and we see them not infrequently. But again, you see the ST elevation in 2, 3 AVF. With some pretty impressive ST depression in V1 and V2, reflective of that electrical abnormality in the heart on the backside. And then the left bundle branch block, according to the guidelines, in any patient with chest pain that doesn't have a previous EKG or a known left bundle, a left bundle branch block by itself is considered a ST elevation myocardial infarction equivalent. So we treat those patients as such. And then with people that have a known left bundle, there's actually some changes that occur called the Scarbosa criteria. Particularly, you see it in the precordial leads. In this example, V3, V4, you can see compared to the normal left bundle on top, you have pretty impressive ST depression, kind of in those leads in particular. So when those patients have that and they have a known left bundle and they now have the Scarbosa criteria, again, we treat that as an acute myocardial infarction. So statistics for myocardial infarctions or heart attacks, approximately 805,000 myocardial infarctions occur every year nationally. So about every 43 seconds, there's a heart attack in the United States somewhere. About 605,000 of these are going to be first-time events. About 200,000 of these are going to be repeat events. Most deaths with heart attacks occur prior to getting to the hospital. For most patients who present with a heart attack, the national in-hospital mortality depends on which source you want to use, but ranges from about 6 to 8% in patients that are treated with primary PCI, and 10 to 16% in those treated with fibrinolytics. Obviously, our goals are to try to get those numbers down to as close to 0 as possible. And then those patients who actually present with severe heart failure and shock, the mortality is greater than 25%. So those patients are critically ill and require a lot of maintenance early on, and try to do everything we can to support them. So to transition a little bit, what kind of symptoms go along with having an ST elevation myocardial infarction? Classically, we think of chest pain. Chest pain means different things to different people. For most, though, it's going to be either a crushing or a squeezing sensation across their chest. It can be a burning or boring sensation, and it may or may not radiate up into their neck or down their arm or through to their back. Usually does have associated shortness of breath and may have nausea, vomiting, and diaphoresis or sweating. And then there are always those challenging cases out there that are atypical presentations. And we think about that mainly in women and diabetics, just because their nerve system may be a little bit different. This is a cartoon from Dr. Netter. He's one of the godfathers of drawing out kind of the body's anatomy. But we got the guy leaving probably the Italian restaurant, carrying his heavy briefcase. He's probably on a business trip, clutching his chest. He just dropped his cigarette, and kind of all the usual spiel we see. So this is an interesting slide, and the fact that it is this is a heart attack in evolution. So if you can see the bottom part of the vessel, you'll see that the plaque is actually forming in that vessel. Initially, it pushes the vessel out on the bottom, but eventually the vessel doesn't relieve any. So then the plaque keeps building up in that artery, and it starts encroaching on the lumen of the vessel itself. While it's encroaching on the lumen, it builds up more and more, and that blockage on the front part in particular, there's something called a thin cap fibroatheroma, and there becomes stress on the vessel. Once it gets to a certain level and that thin cap fibroatheroma is stretched all that it can, eventually it will rupture, as we see here, and the plaque that's in that artery will actually come out and go, or the plaque that's in the sidewall of the artery actually goes out into the arterial lumen and includes the vessel. So the blood flow basically stops at that point, and that basically is the heart attack. So when we get in the cath lab, those are the vessels that we try to find and work on. There are different treatment options for people that have ST elevation myocardial infarctions. Fibrinolytics are the kind of the first thing that we had available to us going back multiple decades. These are considered quote unquote clot busting medications. This is not really the preferred option at Freeman. We do it sometimes, but it is used at some outlying facilities, particularly if there's going to be a delay in transfer from the outside facility to Freeman. It is effective in some patients, and the data would suggest that up to 12 hours from symptom onset, they can still be used and have some effect. It's ideal to be given, though, within the first 2 hours of symptom onset to really get the most of benefit of the drug. Once the clot has had kind of longer than that, it sets up and it becomes a lot more challenging to just dissolve. These patients, even though they get fibrinolytic therapy, they may still have a coronary angiogram when they present to the hospital if they're having ongoing symptoms and don't have any resolution of their ST elevation on the EKG. Or a lot of times, even if they cool off, we want to know what the coronary anatomy looks like. So a day or two later, we'll take them back to the lab and look at the coronary arteries and see what kind of revascularization strategy may be necessary. When patients get lytics, there is a higher risk of bleeding and cardiovascular complications. And particularly if you give them at like the 14-hour mark, 16-hour mark, and those kind of things, it really just increases the complication rate without adding any benefit. A lot of these patients will also be given heparin and Plavix kind of as a co-administration. That's part of the guidelines. It's attacking multiple portions of the clotting cascade. As always, though, when it comes to fibrinolytic therapy, we do have to respect the contraindications. These are very potent blood thinners, and they do exactly what they're supposed to do. Increased risk of stroke, increased risk of bleeding from other episodes, whether it be a recent surgical site or other injuries. So we do have to keep that in mind when we're choosing those out. Another treatment option for STEMI is a primary percutaneous coronary intervention, which is also known as stenting. So that is our preferred method of revascularization at Freeman. The patients go directly to the catheterization lab for a coronary angiogram, which is just injecting contrast directly into the coronary artery, and an intervention, which usually involves inflating a balloon into the artery. We may do some sort of thrombectomy where we suck out clot. Often we'll do what's called an intravascular ultrasound assessment, where we actually measure the size of the vessel directly so we can choose our stents a little bit more accurately on what the size is needed. And then obviously the stenting procedure is putting glorified chicken wire in the vessel to prop it open and try to keep it from reclosing, if you will. Sometimes these patients even bypass the emergency room. They go straight from the field by EMS to our cath lab, and we certainly have done our best over the years to try to streamline the process. You know, you guys are out in the field, and we certainly appreciate what you do, and we respect your knowledge and wisdom about this. And you know, when you recognize a STEMI, the last thing we want to do is have any delay in care for that. These patients usually get preloaded with aspirin and heparin, or aspirin and bivalrudin. That's usually done in the ER, but some rigs occasionally do that as well on the way in. Some of the outside facilities load Plavix, Brilinta, or Effient. There's a plus minus for that. Certainly it makes sense if the patient is going to get a stent. If that patient needs bypass surgery, though, it kind of dramatically increases the risk of bleeding post-bypass. So it just becomes kind of a balancing act on what we can and can't do. And, you know, obviously we want the best for our patients. And the great news is the vast majority of these patients are going to be stentable. So that's not really a delay in those cases. But on the patients that need bypass, we might have to cool them off for anywhere from 2 to 7 days to try to let those medicines wear off if they're going to go for specifically bypass. So when we talk about primary PCI or stenting, there's kind of 2 different types of stent out there that we have available to us. The minority of patients now get bare metal stents. Those are literally just metal stents that go in the artery. These patients that get these usually have known prior poor compliance, so they don't really take medicines reliably. They have a known pending surgery, or they have a high bleeding risk. When we use a drug-eluting stent, which are by far the most common stents that we have out there now, the patients do have to have dual antiplatelet therapy for a longer period of time. So they need to be on either aspirin and Plavix or Effient or Brilinta, preferably 6 to 12 months. And in the setting of a heart attack, it's actually recommended 12 months of therapy for dual antiplatelets when those patients present with a heart attack. Drug-eluting stents, though, for the most part, have less restenosis in the long run. So when we look at the data on that, most of the current generations of drug-eluting stents, the re-narrowing rate is about 3 to 5%, depending on which data you want to look at. But some patients, again, still go for coronary bypass grafting. I think across the nation, that's around 5% or so. But I haven't seen the most recent statistics within the last couple of years. But that's where it's been in the past. Let's see here. So to that end, I'd like to present a case. This is a 49-year-old woman. She had a history of coronary artery disease with a prior intervention several years ago. And she wasn't exactly sure if they did a balloon number or if they did a stent or something else, but she knew something was done to her heart. She presented to the emergency room with 8 out of 10 chest pain. She described it as a substernal squeezing sensation. She said it was similar to her prior cardiac events, but it was much more severe. She also had associated shortness of breath, nausea, and sweating. She denied any other symptoms with it. Her cardiac risk factors, she had known coronary disease with a prior intervention, high cholesterol. She was continuing to be a smoker. She acknowledged that she hadn't really taken medicines for a while, and she had a maternal grandfather that actually had a heart attack in his 40s, and he ended up dying from that. So this was her initial EKG. It's sinus rhythm, we can see that, but when we look at those inferior leads, it's very suspicious for that hyperacute T wave, ST elevation phenomenon. She actually has a little bit of a Q wave already in lead 3. It's hard to say about AVF because there's not much voltage in the QRS complex there, but certainly there's a little bit of a reciprocal change up in AVL, so fear for an acute inferior myocardial infarction. So the patient went back to the catheterization lab. This is the initial angiogram of a right coronary artery. I would draw your attention kind of here to the mid portion of the vessel where there's an abrupt termination. This patient's interesting in the fact that she has a coronary fistula. So her acute marginal branch comes over here and has this rat's nest that develops and goes into the most likely the right atrium or right ventricle and kind of fills that up. But I would say it's actually the right ventricle based on where it's located. But again, abrupt termination of that. So the next picture shows us that we basically have a wire down there. This is a stent being implanted to try to take care of the problem. When we look at the next picture, again, still have that, but this is our angiogram after we put the stent in. So where there was an abrupt termination of blood flow here, now we see that whole vessel's been restored, and there's a sizable right posterior lateral branch and a right posterior descending artery as well. That lady did well and went home on her dual antiplatelet therapy, and surprisingly was lost to follow. So we talk about different things when it comes to ST elevation myocardial infarction care, and one of those things is called the door to balloon time. So from the time the patient arrives to the emergency room, has their EKG, to the time we inflate the balloon in the artery or do any type of mechanical intervention in the artery. We know that if we can do it faster, that's less risk to the myocardium as far as permanent damage. So ideally we get it down to as low as possible, but the magic number in the guidelines is 90 minutes. And when we look at the 30-day mortality, that's part of the reason. When you have less than 90 minutes, and that 76 to 90 minute mark, you have about a 4% risk of mortality. If you can get it less than 75%, it's 3.7. If you get it less than 60 minutes, it's 1.0. So certainly better numbers. But once you start getting greater than 90 minutes, and particularly if the patient doesn't have anything done, that mortality from the myocardial infarction goes up fairly dramatically. And we can break it down kind of in all patients. When we look at the survival over time, when we look out to 11 years, you still see there's disparity from the people that had it within the 90 minutes up here on the blue line. I guess it's purple, I'm sorry, versus the patients that were never revascularized. So it's not just the initial benefit that the patient receives from revascularization, but it's a lifelong thing as well. So our Freeman door to balloon time is about 65 minutes right now. It puts us in about better than the 40th percent nationally for this measure. We're trying to work on that. I think a lot of our door to balloon time adjustment has been kind of from outside hospital referrals and just trying to get those patients on the clock as soon as they arrive at the door there, getting the ambulance service wherever it may be and getting them to the cath lab as soon as possible. We kind of have a policy with our staff at Freeman. Everybody that's on call for the cath lab has to be back in the cath lab within 30 minutes of the pager going off and ready to go. So most of the time, as you guys show up, you'll see we're in the lab ready, waiting, and hoping to get things moving. Our cath lab volume has been pretty remarkable over the years. You can see when we look at the total numbers of cases we do, we're roughly around 4,000 cases a year, give or take. When we look at our ST elevation myocardial infarction, 209 kind of seemed to be the heyday back in about 2021, so during COVID. But it's been steadily going down over the years. We're still kind of working on that. But I think it is one of those things that it's an important part of our practice and a service that we want to provide to the community. And then when we break down how the ST elevation myocardial infarctions happen, again, when we look at kind of the most recent numbers, the in-house STEMIs were for patients that were already admitted to the hospital. That seems to be kind of on the low end side of it, as our walk-in STEMIs transferred from outside hospitals and EMS bring the vast majority of our STEMIs to us. And when we look at the patients that actually get lytic therapy, that's in that far column over there. TPA is the lytic that we usually use. You can see those numbers are pretty small. So we do try to take everybody to the cath lab for that primary PCI or stenting procedure to give them the benefit that we can. We have gotten awards over the years for cardiovascular care. Freeman Health Systems is one of only 14 hospitals in Missouri designated as a level 1 STEMI center by the Missouri Department of Health and Senior Services. So we work very hard with that again, trying to get the system streamlined to make sure that we get the patients to the cath lab the best way we can, to make sure that the cath procedure goes as planned, and that most importantly as well, it's not done in the cath lab, it's what happens afterwards too. How do we get patients on the medicines they need to be on? How do we get them the support system that they need? Getting them into cardiac rehab and kind of trying to benefit those. We have won awards for both our non-STEMI and STEMI care, and also our chest pain and MI registry from the American College of Cardiology. So we're proud of those awards, and we'll keep working to always get better. So some other STEMI therapies that we kind of look at, and this was kind of more of an old nomenclature that when I went through my residency and fellowship, we talked about a lot, but monobistatin was the mnemonic that we used. And I think a lot of people still kind of go with that. M is for morphine. Usually it's only for patients that have severe pain. It potentially could interfere with Plavix and Effient absorption. So sometimes people don't use that. Fentanyl is an alternative to morphine. There may also be a little bit of interference with that drug. So we kind of keep that in the back of our mind. But, if somebody's having severe pain, the last thing you want to do is leave them in that. The more pain they have, the more adrenaline they have, the higher their blood pressure is going to be, the higher the heart rate is going to be. So potentially keep that infarct going. Oxygen, back in the day, everybody got thrown on oxygen. And now we really reserve that for patients that have low oxygen saturations, as in people that already have high oxygen saturations. When they get put on oxygen, it may actually increase free radical release and cause more myocardial necrosis. So if they're not really hypoxic, they don't need the oxygen as much as we thought they did. Nitroglycerin, again, trying to treat the pain the best we can. In people that are having inferior infarcts or hypotension to begin with, though, if you give nitro, a lot of times that blood pressure is just going to get that much lower. So we have to be cautious with that as well. That being said, your classic anterior STEMI, your lateral STEMI, those are usually going to tolerate nitroglycerin well. Aspirin, 325 milligrams is the preferred dosing regimen, usually chewed to patients that are having chest pain symptoms and having a STEMI. Beta blockers come in and out of favor. I think initially when people have very high blood pressure, very high heart rates, then a beta blocker is a good option because it kind of helps to lower both of those. But I think in the long run, we're going to find that beta blockers are great kind of for initial therapy, but sometimes the side effect profiles for a lot of patients and stuff like that make them a little less favorable. I still use them pretty aggressively in my practice, however. And then statins, particularly atorvastatin, there's data if it kind of gets loaded up front in somebody that's having a heart attack around the time of the stent implantation. they're going to do better. But certainly we also know kind of a more long-term management in these patients. We want to keep the cholesterol down if we can, because the less cholesterol floating around in the bloodstream, in theory, has less cholesterol building up in those vessels and kind of causing problems. And particularly when stents are first healing in, we want them to heal in and endothelialize from the natural skin that will grow from the artery over the top of them. And hopefully it's just the natural skin and not have a bunch of plaque deposited on it as well. That plaque, when it gets deposited on there, is a part of the scarring process that can re-narrow that stent. And although it doesn't happen as much anymore with the drug-eluting stents, it is still a possibility. So there are different mechanical support options for our patients when we kind of see how sick they are, particularly those patients that are in cardiogenic shock. Sometimes the revascularization procedure by itself is not enough. So we need to do something to support that blood pressure or improve coronary perfusion pressure. At Freeman, we have the intra-aortic balloon pump and the Impella available to us. ECMO is something that we work with other hospitals to try to provide for some patients. And then left ventricular assist devices are traditionally reserved for academic centers. But the intra-aortic balloon pump, it's one of the first support devices that was available for patients. It provides about 0.5 liters per minute of support. So not a whole lot, but it's enough to kind of let the heart rest a little bit, but it also helps with the coronary perfusion pressure. So when that balloon inflates, it forces the blood kind of backwards and forwards, which some of the backwards goes down the coronary arteries. I had a case of a gentleman the other day that had a heart attack, and even though he had gotten the stents in and given him a bunch of blood thinners, he still had kind of a slow coronary perfusion. So I put him on a nitroglycerin drip. I put the balloon pump in, and the pressure, the coronary flow got much better, pretty remarkably, actually. So we just left that in and let him cool off, and he's doing better now. These do have decent sized sheaths associated with them, so 7 to 9 French sheaths. Most of our coronary interventions in our institution are done through 6 French sheaths. 7 French isn't that much bigger, but when you start getting to 9 or start talking about 12, 14 or bigger French sheaths, and then that just increases the risk of vascular complications from those procedures. A balloon pump's nice in the fact that it can be left in for 14 days, and our machines actually provide invasive hemodynamic monitoring. So we can kind of see what the blood pressure is inside the body as opposed to trying to rely on just a blood pressure cuff or an art line somewhere else. The Impella CP is kind of a little bit more potent. It's not been around as long as the balloon pump, but it does provide a larger amount of support. And these Impella devices that we have, the CP is about 3.5 liters per minute. We do have what's called an Impella 5.0 that also can go up to 5 liters per minute. That one's actually a surgically implanted device. You do need more aggressive vascular access with these, though. So there are 13 French as opposed to 9 French, which is it's a bigger hole in that artery. So when you have that, it definitely can increase the risk of those complications, whether it be bleeding or trauma to the vessel. So we usually take a picture of the arteries before we ever put these things in to see what kind of vessel we're dealing with and which device it would actually handle. These can be left in for up to 5 days. Again, vascular access is usually the limiting factor, but this has a propeller in there. So it basically will suck blood out of the left ventricle from the bottom part of the propeller, which is down here, and then it ejects it out of the top part up here. Into the body, and it's pretty remarkable device, and it can pretty much provide most of the support that the heart needs for functioning for a while. ECMO is another kind of a next step up, if you will. This is not currently done at Freeman per se, but you can provide total support to the heart. It requires a perfusionist to maintain the machine while it's in place, because it is a form of basically just oxygenating the blood outside of the body to make sure that the patient's getting what they need. It is not really ideal for long periods of time as far as days go, because it does contribute to hemolysis, so breaking down the blood counts. You can actually get platelet aggregation, so it can cause some clotting to form in that area, and you can lose platelets as well. Again, these also are large bore access devices, so the holes in the arteries and the veins are going to be pretty big. It's generally better for pediatrics, for adults as far as the overall statistics go, but there is some data out there, particularly in those really critically ill adults, of getting some benefit from it. So it's kind of one of the next level. You've tried the balloon pump or you've tried the Impella and the patient's still just not getting better. How do we keep moving forward to try to get them a higher level of care? And then the left ventricular assist device, these are pretty cool, I have to say. When I started my cardiology training a couple of decades ago, These were still relatively young and in their infancy, had a ton of complications from them and things like that. But as the technology has evolved, they've become smaller. People can be more mobile with the devices. These are not done at Freeman. Were initially used as bridging therapy for patients that had advanced heart failure and they were waiting on a transplant. So they had these devices put in, and they might be in for several months to, a couple years. And then eventually the ultimate goal was to get them the heart transplant so they could have this device explanted, have the new heart in, and go on with hopefully a long, healthy life. Now, though, they do something called destination therapy. So there are some patients out there, whether it be their age or their other medical problems, that are just never going to get a heart transplant. So they end up getting one of these devices, and they'll have it the rest of their days. And there's no, basically, there's no goal of getting them to the next level, because this is the last level for them. These can be left in for an indefinite period of time. I think the longest patient that I have right now that has one is about 3 years, and they've done really, really well with it. So this can provide total cardiac support with minimal and native cardiac function. In fact, the person that I'm thinking of right now, when I looked at his heart, it was basically there was a quiver of a little part of the bottom part of his heart, and that was it. The rest of his heart wasn't moving at all. But when they put this device in, his kidney function got better, his liver function got better. He had swelling basically all the way up to his scrotum, and that resolved basically once this device went in. It took a few weeks, but he just became a new man. It was remarkable. This is the most aggressive and invasive approach for support. It does allow the heart to rest and recover after a myocardial infarction. And like I said, this is pretty much the most aggressive thing you can do. And that's why it's reserved mainly for academic centers. We wouldn't do this very often. And for us to try to implant one of these once every 2 years is not really great for patient care. So we usually transfer patients on for those. There are a lot of things we do kind of after somebody has a heart attack. We call it the ABCs of cardiology. Aspirin is a big part of this. Most of the time, patients go out on a baby dose aspirin, so 81 milligrams, mainly because they're going to be with another antiplatelet agent. The 3 antiplatelets that we choose from, Brilinta is one of the specific ones. So with Brilinta, though, and I always remind people of this, if you're going to be on Brilinta, the only dose of aspirin you can use with that is actually 81 milligrams a day. If you use the full dose of aspirin, for whatever reason, it interacts with the Brilinta, and you actually lose some of the effect of that drug. So you can actually have stent thrombosis from that. So Brilinta and a baby dose aspirin. This is different than Plavix and Effient, where some patients that have atrial fibrillation, kind of an old school thing was they were on a full dose aspirin for the atrial fibrillation, and then they would be on Plavix and Effient. You can get away with it in that scenario, and it doesn't seem to have the same effect. But traditionally, now when patients leave the hospital, it's 81 milligrams of aspirin, one of the antiplatelet agents. And then there's a lot of things that we call guideline-directed medical therapy. So ACE inhibitors or angiotensin receptor blockers in patients that have a pretty depressed ejection fraction. There are things out there called angiotensin receptor neprilysin inhibitors, or ARNIs. Entresto is the other name for that. That's the easy way to remember it. But that's the only ARNI on the market right now that's traditionally used. But each one of those kind of has a purpose to help the heart recover some function, help with the blood pressure, and just hopefully with what's called endothelial function. So the vessels themselves have an inner lining called the intima. That's what the blood sees. The media is actually a muscular layer. And then there's the advent tissue, which is the connective tissue kind of outside of the artery. What we hope when we use ACE inhibitors and those other agents is that muscle layer can still contract and relax. And that's endothelial function in a rough sense. And we just want to try to preserve that as much as possible. Aldosterone antagonists, spironolactone and eplerenone, are the 2 agents that we kind of use. There's a newer one, Finerone, that's out. The newer agents are pretty expensive, so we don't really use those quite as much. Spironolactone works, it does what it's supposed to, but you do have to kind of follow some blood values when you use that. Again, beta blockers, similar to the acute myocardial infarction. Right now, we do still use those as a part of guideline-directed medical therapy. Cholesterol medicines, again, the first several months that these stents are in, we want to try to get the cholesterol down as low as possible to allow the stent to heal in and hopefully not develop a lot of cholesterol sticking to it and other places. I will say that the cholesterol world is changing. We have the classic medicines called statins. So atorvastatin and rosuvastatin are the 2 main ones that we use for this now. But the new kid on the block, and I say that somewhat tongue-in-cheek because they've been around for a while, but they're called PCSK9 inhibitors. So this is a whole new way to manage cholesterol. The ones that are kind of around here traditionally used are Repatha, Praluent, and then Leqvio. So Repatha and Praluent are injectables that go every other week, basically. Leqvio is pretty cool because it's a twice a year infusion at the center, but those get crazy low cholesterol numbers. I've seen an LDL of 177, and traditionally when we break down cholesterol, we kind of look at it, people want to talk about the total cholesterol, but that really is not how we specifically look at it. LDL is the quote unquote bad cholesterol. And that number in patients that have had heart attacks, we want to get that number 55 to 70 now. Ideally as close to 55 as we can. We look at triglycerides as another breakdown, trying to get those less than 150. And then HDL is a challenging one. A lot of times it's great genetics that keep your HDL up. A lot of diet and exercise things help with the HDL, but there just aren't great medicines right now that raise HDL. We used to use niacin all the time for that purpose. And then there was a trial done called the AIM High trial. It's been about 15 years ago now, at least. And basically that trial showed that in some patients on niacin, it actually caused harm more than helped. So it's kind of fallen out of the wayside. So HDL, you kind of either have or you don't. But back to the important point, when we talk about PCSK9 inhibitors, I had a patient that got placed on one and their LDL was 177 and it dropped to 44, which I've never seen that with a statin by itself. So no, 1044. So it dropped to 44. And that was a pretty remarkable change. With the statins, you can on high potency statins get about 50% reduction in your LDL, but beyond that, and that's not all the time either. Some patients just you might get 30% reduction, but that goal now being 55 to 70, that's very aggressive. But I think the other thing that has come out of some of the PCSK9 literature is not only is there plaque stabilization, but in some patients they actually show signs of plaque regression. By no means is it going to be a 50% reduction in your plaque volume, but if your plaque is stabilized and it drops by 5%, that's pretty remarkable in these first generation of these drugs. I wish that happened across every patient in there, but it is something that we're hoping to see in the next generations. Maybe it will be 20% plaque rate reduction or more. Ultimately, if we can get people on medicines to take care of these and not have to do all the interventions, it's probably going to be better for the patients. Smoking cessation kind of goes without saying, and we try to avoid chewing tobacco or e-cigarettes if we can. Those agents all do have a tendency to impact blood pressure, heart rate, and those kind of things. So if we can just avoid them in general, that's better for the patient. Ironically, we are starting to get some data now with smoking marijuana, and that it actually can increase the risk of having heart attacks and other things as well, which was, I think a lot of people are kind of surprised by that, and even the edibles may have increased adverse events. So I think it's great in some regards that it's legalized now because people can actually do research and kind of get the data to support pros and cons. But until we have really randomized controlled trials over a long time, it's always kind of been guesstimating what's the real effect. The diabetes medicines are really an interesting thing because they're changing the landscape in cardiology. First, it was the SGLT2I inhibitors. Jardiance and Farxiga were kind of the names of the ones that were mainly pushed on the cardiology front. But the reason that those have been a benefit is they actually help with cardiovascular function, heart failure, hospitalizations, and potentially even mortality. And now the European Society of Cardiology had their meeting, and it was all about Ozempic, Wegovy, Mounjaro, and Zepbound. Really focusing kind of on the semaglutide, which is Ozempic predominantly, and showing the benefit of those. And there's some thought process it's going to help with not only heart failure, hospitalizations, but reducing future myocardial infarctions and potentially even long-term with mortality. So it's kind of an interesting thing where we're in the infancy of these drugs, but the benefits are getting some of the trials to just really stop even a little bit early, just to say, hey, we're noticing this trend. You guys pay attention. So I think we still need a lot more data, and definitely it's another one of those things that we need this for around for decades so we can see how it's going to benefit the population. But so far, these are not just diabetes medicines that lose weight. They help with heart function, they help with kidney function and things like that too. So to be determined, yeah. But diet, the Mediterranean diet is something that's recommended by the American Heart Association, the American College of Cardiology, the American Diabetic Association, really just trying to focus on, fruits, vegetables, fishes, oils, and nuts. People always raise their eyebrows when I say fishes or fish, but you can You can eat pork, turkey, and chicken. Beef is not the staple meat though. You can have some beef every once in a while, but a cheeseburger a day is probably not going to be the best thing for you. But those other protein sources are good. Exercise, we do recommend cardiac rehab for patients that have had heart attacks, with the hopes that this is going to start lifelong fitness for them. Also gives them a support structure to let them be around people that have had heart attacks and other events, so that they can really try to get the most out of that that they can. And then lastly is fun. It's kind of an interesting thing to think about, but you can imagine, particularly a young individual that's had a heart attack out of the blue, that's a life-altering event, and they're not going to be the same after that. So trying to recommend, or at least recognize the stress from that, and let them know that there is a life that can happen after that, and they have the potential to still have a good quality and quantity of life. So lots of resources here. And then the current cardiovascular team at Freeman. And thank you for everybody for your time, attention, and most importantly, all that you do. We obviously would not be successful if our job, if you guys didn't bring us the patients in a timely manner and take the best care that we can in the community. So thank you. Anybody have any questions?
A little bit of a delay from the national secret goes on.
Out of respect to you, I was not wanting to disrupt you again, but I had to go to the camera view. I probably made a few people nauseous with my inability to hold perfectly still.
Well,
I'm not a tripod. Just lay that out there.
Your computer must have disconnected again.
Didn't want to be doing that time and time again. So we got great audio, and I just did video.
okay.
It looked good.
Other than it constantly moving because I can't hold perfectly still for 40-some minutes. It's just not wanting to interrupt you again.
Well, I appreciate that.
The GLP-1s are having a dramatic benefit.
They are. Yeah, they think that there's going to be, and it's not just for like one organ system. It seems to be across the body. There's a pretty cool, there was a YouTube video that they put out, and it was showing a kind of somebody that has, we used to call it NASH, the non-alcoholic steatohepatitis. Now they call it MASH. But they showed the liver kind of like around, I think it was May, and basically they put them on, I want to say it was Ozempic, but it was one of the GLP-1s, and then they followed up on it like 6-8 months later. And when they took the same PET scan of the liver where all the fatty infiltration had been, it was nearly gone. And I think that's pretty much a dramatic response. I don't know that everybody's going to get that, but they're just kind of showing that, this isn't just about blood sugar control. This is kind of looking at the body in general and all the organ systems that are affected. And right now, it's kind of interesting when we talk about the SGLT2 agents. When Jardiance and Farxiga got moved onto the cardiology guidelines, they actually got ranked higher than in our guidelines than some of the ACE inhibitors, angiotensin receptor blockers. And that was one of the first times that a diabetic medicine moved in above cardiac medications for cardiovascular care. And I think that paradigm is going to keep moving forward as we get more and more data on these other agents. But it's an interesting time to be in medicine because I think medical therapy is getting so much better. We just have to really lay the foundation at an earlier age so that people recognize. And I think that's where we have to be responsible to our teenagers, our young adults, and really get them engaged in physical fitness and appropriate dietary choices, obviously appropriate lifestyle choices. Because I think one of the alarming trends that I've seen, and there's not data necessarily to support this per se, but we're seeing younger and younger people have heart attacks. And what was unheard of decades ago is, I won't say normal, but I've had a heart attack. The youngest one I had this year was 21 years old, and that was a very surprising case. I will admit there was substance abuse several months before that, so I can't say that didn't cause some unstable plaque. But this individual had been clean for 3 months, and it was known that they were actually clean because they were in a facility and got routinely tested and all those things. And they still had a heart attack. And when you have a heart attack that young, people just discount that person with chest pain because they're like, oh, they're too young to have a heart attack. And then they got the EKG and like, oh my gosh, you're having a heart attack. And so that's a big deal too, because in a 21-year-old, it's a bigger effect lifelong than it would be in an 81-year-old, right?
Also on the GLP, what about the plaque buildup in the coronary?
Yeah. And that's yet to be determined. We're assuming that that's going to have a benefit in the long run because, in theory, if you make the diabetes better, it's going to help with the plaque issue, going to help with the cholesterol issue, and those kind of things. But that's a theory, and that's the drawback about these drugs. We're excited about them, but they're still relatively in their infancy when we compare to what we've had around since the 70s and 80s, and kind of have a predictable pattern of what's going to be there. And that's the other thing with any of the new drugs. We also don't have a long-term side effect profile. We assume that the side effect profile is going to be okay, and it's something that they obviously collect data on, and that's why they have registries and stuff. But I always tell people there's no such thing as a free ride in medicine. Everything we do to our body is a controlled toxin, whether that be medicine, whether that be herbals, whether that be what we're eating or not doing. But those all impact our body in a positive and sometimes a negative way. So that's why, in my practice, I try to minimize medicines as much as possible because we don't know all the drug interactions that can happen. And if somebody comes in on 24 pills, it's not if they have drug interactions and those kind of things, it's how many are there. And you can plug it into Dr. Google and say what's going to happen here, but every individual is different. So you can't say that this cocktail that works for this individual is going to work for another individual. So you really do have to tailor it to the patient. And I think, another things that we have to consider are financial constraints. Some of these medicines are $400 to $500 a month after insurance, which to me is completely ridiculous, and we have to figure out a better way. But some of these other medicines that work very well are dirt cheap. So I try to stick to the cheap regimen as much as I can. We obviously try to get financial support for a lot of our patients and get them plugged into programs where the drugs will be paid for. And those are the things that we try to do to help our patients. But I think another thing is that people do have to take ownership for themselves. We can turn blue in the face and try to give them all these algorithms and guidelines and all this stuff, but if they don't really follow it, then they're not going to get the benefit from it. And in some of these drugs, if you're not being monitored and taking them appropriately, they can actually cause a lot of harm. So I think that that's again, it's a mutual decision and what we call informed consent. We want to educate our patients so that they understand why we're doing what we're doing, and really spend time with them to kind of have little things to look for as well. I think statins, cholesterol medicines in general have a bad reputation because when somebody Googles statin, the first thing that comes up are the 25 bad things that can supposedly happen from them on all the patients. But when you look at the actual statistics, really it's the vast minority, and we're talking way less than 5% of patients that have really an adverse reaction to statins that cause a major problem. So that would mean, greater than 90% of those patients that take statins are going to be just fine. But there's just this perception. And we have some people that have heart attacks and they just absolutely refuse statin therapy. And that it's challenging to try to deal with that because knowing that, particularly the first several months after a heart attack, that's the sweet spot to try to get all this under control. So, but that's just one example. I mean, there's like lots of stuff out there. Any questions have come in so far?
Funny comments about, thank you and thank you.
Sure.
Thank you.
All right. Well, I appreciate everybody's attention, and I will try not to waste any more of your time, and I hope you guys have a great rest of the day.
We will be back at, you got me online now?
I do.
Yeah. Or we'll be back at 1 o'clock. So go enjoy lunch. See you at 1.
Eat